Hey everybody! So today we are talking about total shoulder arthroplasty, which I find extremely interesting. And as you will see, these are surgeries that are getting done more and more. And so you might be running into them more frequently than you were maybe 5 years ago. It's kind of like the labral repair that we just talked about. And so I'm hoping that you'll find this interesting. We're going to do this one in two parts. So the first part today, we're basically going to go up until through the surgery. And then we will talk a little bit more about the rehab in the next section. So I don't want to spend a whole lot of time going over anatomy. I'm hoping you guys are aware of anatomy related to the shoulder. What you just kind of want to remind yourself is that there's actually 4 joints that we would call the shoulder complex. So put together, we have the glenohumeral joint, the acromioclavicular joint, the scapular-thoracic joint, and the sternoclavicular joint. And it's important to keep that in mind because what you'll see as we talk about all of these things is that the shoulder arthroplasty or shoulder replacement is just the glenohumeral joint. But as we start to do rehab, we need to really consider what's going on at the other joints. And you're going to see how important that is, and how important it is for us to continue to focus on helping those joints move really well, because we may not be getting the same motion and the same movement patterns that we would expect following the surgery. And so we want to make sure we're aware of all the different pieces of the shoulder joint. The other thing you want to definitely be aware of is how the glenohumeral joint works with the scapular-thoracic joint. And it's really important that you're aware of what we call the scapular-thoracic rhythm. Recognize that the movement of the scapula to the glenohumeral joint is what we call a 2-to-1 ratio. And so we have approximately 60 degrees of our overhead movement comes from the scapula, and 120 degrees comes from the glenohumeral joint. And the scapula does not really start moving. You'll notice in this picture here, we would say until about at least 30 degrees of overhead movement. Other people might say 60 degrees of overhead movement. And so what you want to just recognize is that you have to have good mobility of the scapula as well as that glenohumeral joint to get your overhead movement. So that's going to be an important thing to keep in mind as we talk about these shoulder replacements and reverse total shoulder replacement, which literally changes the head of the humerus into the acromion and the acromion into the head of the humerus. Pretty cool surgery. That's one of my favorites. This is just another picture that shows, again, that important dynamic relationship between the scapula and the humerus, and how our rotator cuff muscles from all angles are really helping to, and those arrows really are kind of showing rotator cuff muscles, and how those help to stabilize the head of the humerus in the acromion, in the scapula. And so when we move, again, what the main job of our rotator cuff muscles, as I'm sure most of you know, is to help keep that head of the humerus where it's supposed to be, so that we don't have too much excessive movement around the scapula, which can then cause impingement, pain, lots of different problems. And so what you're going to see as we talk about these surgeries is that this will definitely change with a lot of these patients after the surgery. And so this idea of mechanics is something we have to consider as we go through this. The last thing to consider is this idea of the scapulohumeral rhythm and the primary movers of the scapula for upward rotation. So it's really important that you're aware of the fact that the upper trap needs to work with the serratus anterior and the lower trap, and those 3 muscles have to work together and equally to allow for upward rotation to occur correctly. And so unfortunately, I'm sure you've noticed what you see a lot of the time with a lot of your patients who have shoulder pain is that they overuse their upper trap, maybe they overuse their deltoid, and they're not using their lower trap and serratus enough, and so they end up again with impingement problems. And this is an important picture to keep in mind as we talk about shoulder replacements, because in theory, all of these muscles in this picture, the upper trap, middle trap, lower trap, serratus anterior, and deltoid, should be intact following a shoulder replacement. So we should be able to get those muscles to work to help with overhead movement. So shoulder replacements, as I kind of alluded to at the beginning, at least on the Western research, the number of total shoulders has increased significantly in the last 20 years. So surgeons are starting to get much better at this surgery. I'm not sure what the numbers look like in China. I couldn't find any research specifically related to China. I've only seen one total shoulder, and it was actually a reverse total shoulder. And I think it was because of a fracture and a rotator cuff tear. And it's the only one I've seen in Shanghai. I believe there was a couple that we saw in Beijing, but it's been pretty rare. And so this is something that you're not going to see frequently, so you definitely want to refer back to this presentation so that you can kind of keep track of how the surgery happens and what to do after surgery. So basically, most of the time that total shoulders are occurring, this surgery is because of osteoarthritis. So this is what you've seen with all of our joint replacements, total hips and total knees, is that we're requiring this surgery because all of the osteoarthritis has led to significant cartilage damage, and possibly into the subchondral bone we have damage. And so it's important that we're keeping in mind that this has probably been, the shoulder problem has been going on for a long time before the shoulder replacement. Also keep in mind that this is a relatively complicated surgery. So most patients in the West are going to go to a rehab facility for a period of time after the surgery. So I know in China it's pretty common. Everybody kind of goes to rehab after surgeries, but that's not necessarily true in the West. This one, however, you're probably going to follow for a good period of time in a rehab setting, inpatient setting, following the surgery. So the possibility of cartilage damage, osteoarthritis, and other soft tissue damage is generally diagnosed using some sort of imaging. And MRIs are going to be able to show the soft tissue damage better. And so you're looking for osteoarthritis, you're looking for rheumatoid arthritis. Rheumatoid arthritis, unfortunately, is a big reason that people require surgery. You're also possibly seeing replacements after a really bad fracture. So really bad humeral head fracture that might have also included the acromion, something like that. I haven't really seen that a lot in China, but I'm sure it does happen. Also, you're seeing osteoarthritis in conjunction with rotator cuff tears, and usually significant rotator cuff tears. So these are all things that the history is going to show us, as well as possibly avascular necrosis. So if you remember, we talked about avascular necrosis with hip replacements, and it's also very common as a problem that might lead to a shoulder replacement. So these are patients that will demonstrate significant decreases in range of motion and strength, as well as a significant increase in pain. And so this is what's going to lead the surgeon to decide that it's appropriate for operative treatment. Non-operative treatment is not done very often. If this is the type of injury and osteoarthritis that is very, very bad, then they're going to choose to do surgery. If you're seeing them in a non-operative conservative care environment, oftentimes they're using a lot of medication to help make them feel better because they have a lot of pain. So they're using a non-steroidal anti-inflammatory drug for osteoarthritis, and they're using rheumatic medications for rheumatoid arthritis. And again, this is ways that that'll help to control the pain. And then we're also providing the patients possibly with modalities for pain control and improving functional movement. So we're really just trying to keep them able to move in functional directions. So for those of you who know me, and I do a lot of lectures on the shoulder, I can tell you the shoulder is by far the most difficult joint in the body. At the beginning of my career, I sort of recognized how hard the shoulder was, and I spent a good year and a half just going to continuing education courses over and over again to try to learn the shoulder better. And after a year and a half, I was like, okay, I'm a little more confident than I was before. And then I started treating patients. And, 15 years later, I said again, oh my gosh, shoulder is the hardest thing and I need to start learning more. And so I've been going to more courses on the shoulder now. And I'll tell you, it's just, some of the big experts would say that it's so much harder than the other joints because it's 4 joints. It's not just one joint. And so when we talk about a shoulder replacement, we're only talking about one joint. And that works just fine for hip replacements and knee replacements where we really only have to think about one joint. But unfortunately, the shoulder is not one joint working by itself. And so, the conservative treatment is going to be a lot of pain modulation and things like that, because a lot of the doctors are worried that if they choose to do surgery and it's not successful, because they might not have done the right thing, then they're going to end up with a lot more side effects and a lot more problems in the future. So it's just a hard one. Shoulders are hard already, and the psychology behind a lot of shoulder problems, which we're not going to get into, also makes this patient population a little bit harder. Muscle guarding and things that our brain really doesn't like things to move while there's pain, and so we really try to avoid that pain, and so we do a lot of muscle guarding, and I'm sure you've worked with patients that muscle guard when you're trying to do range of motion and things like that. So again, if they're choosing not to do surgery, they're going to use things to help control the pain, because that's going to be the most important thing. So when do they choose to do surgery? Rheumatoid arthritis that is significant oftentimes will lead to a total shoulder replacement. So we're going to look at videos for total shoulder and reverse total shoulder, and there are different indications for different ones. So the problem is with rheumatoid arthritis is if they don't do the replacement early enough, what happens is there's actually even more loss of tendon and bone. So it makes the surgery more difficult for the patient and for the surgeon. And so the surgeon really needs to be aware of the shoulder pain for patients who have rheumatoid arthritis so that they can time that surgery to replace the tissue at the right time before it gets too bad. Also, very bad osteoarthritis could lead to a total shoulder replacement. Avascular necrosis, you can see that there in the picture. That can also lead to a replacement. And then there are situations where they can just do a humeral head replacement. And so if there's inflammatory osteoarthritis with some rotator cuff deficiency that's not that bad, but bad enough, they might just choose to do the humeral head replacement. Again, that's going to be less dramatic, less traumatic to the joint. A proximal humeral fracture, I see a lot of humeral fractures here in China. I have yet to see them do a humeral head replacement, so I'm not sure if that's something that's part of the surgeon's repertoire here, but it is in the US, and I've seen it somewhat regularly in the US. And then osteonecrosis of the humeral head. So again, these issues where we end up having necrotic tissue around the humeral head, kind of like avascular necrosis, but obviously different tissue. And so this might lead to just replacing that humeral head. So those are the two options that you probably see the most regularly. And then what I would consider by far the most interesting surgery is the reverse total shoulder. And so reverse total shoulder is exactly what it sounds like. They are literally changing the head of the humerus to where the acromion is and changing the humerus into acromion. So it's changing that to a smooth surface and changing the scapula basically to a round surface. These are done if there's a significantly bad humeral head fracture that I said earlier might also include the acromion. This also can happen if they've attempted to do some sort of humeral head replacement or total shoulder for a fracture and that it didn't take, so that it's a failed surgery. They may choose to do a reverse total shoulder. If there's a lot of rotator cuff insufficiency, so much so that they can't actually repair the rotator cuff very well, then they may go in and just do a reverse total shoulder. And we'll talk about what that looks like. They really don't spare very much of the rotator cuff in these surgeries. So you lose a lot of the rotator cuff with reverse total shoulder. And so if it's a really bad tear or a really bad arthritis that's led to a lot of rotator cuff tearing or injury, then they may choose to use the reverse total shoulder and kind of essentially get rid of the rotator cuff, which sounds a little bit crazy. But for these patients, again, it's all about pain control and being able to function and use the arm. And so this tends to be the best option for them. So total shoulder. The technique is basically, it looks like the picture there. You're going to have, it looks very similar really to kind of a hip replacement. So you're going to have a head of the humerus here with a rod that goes into the humerus, and then you're going to replace a portion of the acromion. They're going to set the head and neck angle to be a little bit different than what we would consider functionally, so it actually sets it at 60 degrees because this allows for better range of motion. Most of the time they're going to come in anteriorly along the deltoid pectoral area, and that just allows for them to reserve as much rotator cuff as possible. But they usually have to cut through the subscapularis. And so you may lose portions of the subscapularis during the surgery. They also may end up getting rid of osteophytes, bony growth, like we talked about with the other joint replacements, and also labral repairs and things like that. And they may repair rotator cuff if they can salvage rotator cuff. So we do have a video for this. I always think the video is probably going to explain it better than I can, so let's watch that video.
Total shoulder replacement is performed when arthritis or degenerative joint disease makes the shoulder stiff and painful. The procedure replaces the bone surfaces of the shoulder joint with a metal humeral head attached to a stem inserted in the upper arm and a specially reinforced polyethylene plastic socket. In cases requiring total shoulder replacement, the cartilage becomes worn and the underlying bone develops spurs and various irregularities which produce pain and loss of arm motion. An incision is made around the shoulder joint. The incision is commonly made along the side or in front of the arm. The muscles and tendons are moved away from the joint to expose the humeral head and labrum. The shoulder is moved to allow access into the joint. The head of the humerus is removed and the glenoid cavity is cleaned out in preparation for the replacement component. The hollow channel inside the humerus is prepared so the humeral stem can be fit into position. Depending on your surgeon's preference, cement may or may not be used to secure the stem. A carefully fitted ball is secured to the end of the humeral stem. The shoulder joint is then rejoined and all surrounding tissues are put back into normal position. Total shoulder replacement can provide complete or nearly complete pain relief in most patients and will allow patients to carry out many normal activities of daily living, light labor, and sporting activities.
Okay, so that's the total shoulder, which again is pretty straightforward. It looks almost like the hip replacement. Even the cement versus non-cement, again, looks very much like a hip replacement. The reverse total shoulder, however, is very different and pretty cool. So because we're changing the joint center of rotation, because the center of rotation is now much more lateral, right? So it's going out towards the outside of the arm. We end up basically using the deltoid muscle to perform what rotator cuff muscles were doing previously. So as I said earlier, and we'll see from the video, sometimes they have to get rid of the rotator cuff muscles completely. Sometimes they don't. But what you have to recognize is because we've changed the angle and where the rotation is happening, the deltoid muscle becomes the compression force for overhead movement. And so if you remember that picture from the beginning where we showed those arrows of the rotator cuff kind of pulling the head of the humerus towards the acromion, towards the scapula, now we have the deltoid muscle actually becoming that compressive force. And so because that's true, and because the rotator cuff may not be spared, may not be continuing to use it, you're not going to get the same amount of rotation, and you're not going to get the same amount of ability to go overhead with this particular surgery. So let's watch the video, and then we'll talk a little bit more about that later.
Reverse total shoulder replacement is a surgery performed to improve shoulder function and decrease pain. This procedure is performed on patients who have suffered massive rotator cuff tears, which have led to a painful condition known as rotator cuff tear arthropathy, or on those patients who have undergone previously failed shoulder surgeries. The surgery removes damaged portions of the shoulder joint and replaces them with a prosthesis. There are 3 bones that are involved in the shoulder: the humerus, the scapula, and the clavicle. The head of the humerus rests in the socket of the scapula, called the glenoid cavity. The rotator cuff is made up of a group of 4 tendons from muscles that surround the shoulder joint, and together with the deltoid muscle, they work to stabilize the joint and move the arm. There are 2 types of total shoulder replacement surgery: conventional shoulder replacement and reverse shoulder replacement. The determination between which surgery should be performed is based upon the strength and functionality of the rotator cuff. For many patients, the function of the rotator cuff has been compromised through massive tears, and the muscles and tendons do not function properly. In these cases, a conventional shoulder replacement may not be effective, and reverse shoulder replacement may be an option. In a reverse shoulder replacement prosthesis, the ball is placed on the shoulder socket, while a cup and stem replace the head of the humerus. This configuration relies on the deltoid muscle instead of the rotator cuff to stabilize the shoulder and provide joint mobility. Additionally, this procedure may be recommended for individuals who have undergone previously unsuccessful conventional shoulder replacement surgery. Depending upon your preference and that of the anesthesiologist, you will be put under general anesthesia and/or a nerve block. Your surgeon will make a single incision through the skin to access the shoulder joint. Your arm is rotated and the head of the humerus is removed. Next, a space is created in the humerus, and your surgeon will insert the stem portion of the prosthesis into the bone. The plastic cup is then fitted onto the humeral side. Next, your surgeon will remove the damaged surface of the glenoid cavity. The first portion of the prosthesis is placed in the glenoid cavity and secured to the bone with screws. Next, the ball portion of the implant is affixed to the previously placed glenoid prosthesis, and the arm is rotated to place the ball into the socket. The incision is closed with internal sutures and either external sutures or staples. Finally, surgical tape or bandages will be placed over the incision. Most patients return home within 2 to 3 days of the procedure. Any external staples or sutures that are present are usually removed in 10 days to 2 weeks. Scarring along your incision site is normal, but it is likely that your scars will fade considerably over time. Your arm will be in a sling after surgery and until your surgeon prescribes therapy. Depending upon your specific needs, your surgeon and physical therapist will develop an exercise routine to gradually increase your range of motion and strength. Your surgeon will recommend when you can return to work, daily activities, and driving. Full recovery typically takes 6 to 8 months.
Okay, so you can see this is a relatively complicated surgery, and it's definitely a long rehab process. And as we're going to talk about in the next presentation, it's definitely a process where we can't expect incredibly amazing outcomes, because range of motion is not necessarily going to improve to their previous level, or normal range of motion, the same as the other side. So it's just something that we would love it if we could give them patient education related to that, but oftentimes we can't. With a total shoulder, a traditional total shoulder replacement, the complications will include glenohumeral malalignment, so the glenohumeral joint not being in the right position. And usually what happens is the humeral head ends up superior to the glenoid. So it's going to sit above it. And it's going to, of course, cause impingement and pain and decreased ability for the supraspinatus to be used correctly. With a humeral head replacement, they may demonstrate just decreased elevation mobility. Oh, I'm sorry. Let's go back to total shoulder. So with total shoulder, the other complication that can occur is decreased subscapularis function. As I said earlier, they may have to completely cut through the subscapularis. They may be able to leave some of it intact, but we may not be able to get as much internal rotation, which is what the subscapularis does, as we did previously. So we have lots of internal rotator muscles that can help the subscapularis, so we just have to make sure that those are working for us to allow internal rotation. So humeral head replacement, basically, we tend to have better strength than with a full total shoulder, but there may be decreased mobility with overhead movement. And then reverse total shoulder, they have a lot of, unfortunately, complications are pretty common. So scapular notching is very, very, very common. And what that means is the prosthesis actually hits up against the neck of the scapula during adduction. So when I bring the arm in, you can see if now the prosthesis is reversed, that I actually would end up hitting that up against the scapula. And so that causes pain. That's called scapula notching. That happens in 2/3 of patients. It's a very, very common issue. And again, I think it probably happens because you don't have a rotator cuff to help pull it down. You're only using the deltoid, and the deltoid is more about elevating. And it's obviously an anterior muscle. It's a muscle that's on the top of the shoulder joint. And so unfortunately it causes that prosthetic to push up and cause that scapular notching. Hematomas can form. There's instability. It could disassociate, meaning the components actually kind of fall out. And then subscapularis bursitis. So there is a little bursa at the subscap muscle, and unfortunately it probably is something that occurs just simply because of the change in movement pattern. So we do have significant amounts of complications that can occur with these replacements of the shoulder. So we're going to stop here, and we're going to talk about the rehab portion in the next recording, the next presentation. So we're hoping to get you back. Again, I just think this is such an interesting surgery, interesting stuff. It's going to be interesting rehab as well. So we're hoping you come back for the second half.